Sure.
Thanks everybody for joining, and thanks Daniela for coordinating. So happy to share updates on silver diamine fluoride that our lab has been working on over the past few years. Thought it would be a timely topic and maybe would generate a great interest. And I think from the amount of people who signed up today for our free CE, I think it is a topic of much interest. Our land acknowledgement at the university, so our U of M campuses are located on the original lands of the Anishinaabe, Cree, Oji Cree, Dakota, and Dene peoples, and of course on the homeland of our Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past and dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. So my disclosures, I need to give some. So I have no commercial or financial interests related to subject matter in my presentation, so specifically no connection with Advantage Arrest. I co-chair the Canada-US chapter of the Alliance for a Cavity-Free Future. I have some different roles with WRHA and Shared Health, and as well currently with CDA's Clinical and Scientific Affairs Committee, but I don't speak on their behalf in this talk. So my objectives for our sort of 40 minutes or 45 minutes of slides, because I want to leave time for questions, is to introduce SDF to you and try to convince you that it has a role as a non-restorative management approach for dealing with caries. I'll share evidence, I think, which is the neat part, is from our recent randomized clinical trial of SDF to manage caries in young kids, and particularly looking at arrest rates for treating cavitated caries lesions. We'll show a couple of slides on if there's an impact on the oral microbiome, and as well, is there an impact on oral health related quality of life. And then just to finish off, I'll go through some tips and also discuss some new and emerging SDF developments in North America. I think that will have a bigger impact for access to care for all individuals, not just children. So what is SDF? So definitely, I think majority of you are familiar with SDF. This is a clear liquid. It is now tinted in color if you're using Advantage Arrest, but this contains silver, ammonia, and sodium fluoride. The silver really acts as an antimicrobial function and helps to kill bacteria. The sodium fluoride helps with remineralization of this cavitated lesion, inhibits demineralization, and also we know fluoride also has antimicrobial properties, and the ammonia basically stabilizes everything in this high concentration in the solution. So we know when we see it marketed, we hear others giving lots of talks and presentations, and there's lots on YouTube if you Google SDF. So we do know its role in arresting dental caries, but also maybe what others don't necessarily appreciate is it can be used as well to manage dentin hypersensitivity in individuals. And we know from the literature that there is an impact on actually reducing discomfort from caries lesions. Theoretically, minimal support from dental staff or equipment are required. I think that's maybe when you have a well-managed, well-behaved patient. But overall, I think it's a very much a non-invasive and safe to use product. You know, I should revise this slide. It's not just necessarily children, but I think in adults as well. But I think we'll talk later about sort of tips on sort of assessing lesions and severity of lesions. It does matter. So it's been used since the 1960s. SDF, though, was approved in the United States in 2014. Advantage Arrest was the product, and it's really currently used off-label because it was marketed as a hypersensitivity product. So its caries arrest functions in the US, it's used off-label. But surprisingly, in 2017, February, Health Canada did approve SDF as an anti-caries agent. So we are a little bit different, our FDA rating here in Canada than in the US. So you're aware, you've seen, likely have all seen cases of this. So we know that the affected and treated areas turn black. But fortunately, you know, the healthy tooth structure will not stain, but you know, there are some concerns as well of discoloring crowns or tooth colored restorations. If you've ever used it, you've likely gotten it on your skin, on your hands. We'll sometimes see patients, if we're not using proper precautions, on their lips or soft tissues. Definitely, we've seen that if we're not careful, it can actually cause chemical burns or irritation to soft tissues in the oral cavity. And as well as, I think, I want you to be aware today and leave this talk realizing that it's not a once and done type of product. So again, if it's not arresting the caries from the first application, you know, if you're not bringing the individual back for recall, decay will continue to progress. And then there's that concern as well. Definitely contraindicated in individuals reporting a silver allergy. I think that the nice thing with this product is now we finally have a secondary form of prevention to manage dental caries. As much as we'd really like primary prevention, where we like to see patients, no patient develop caries, the reality is some will develop caries. And when caries gets to a cavitated stage, we now have the ability to use SDF as a form of secondary prevention to prevent that cavitated lesion from progressing. And so you're going to hear me talk about caries today, the differentiating between non-cavitated and cavitated, because we will talk, and there is a difference, and it does matter what products you use to manage them non-restoratively. So how does it work? Well, really, the SDF inhibits the dentin demineralization. It increases the dentin hardness. Silver actually goes a little bit into the dentin, extends into there, and really preserves the collagen and prevents the collagen from breaking down in the dentin. And so this is sort of the formation of hydroxyapatite and fluorapatite that are formed onto the caries lesion. So before I get into results from our randomized clinical trial, this sort of first started our sort of, we dipped our toe into the SDF sort of research field back before COVID. And so this article actually came out early in wave 1 of COVID. But we wanted to see this product, and we did a pilot study with 40 children from community clinics in Winnipeg. So typically children from low-income households, and we wanted to see the effectiveness in this SDF product along with fluoride varnish in arresting caries in young children, and also looked at measures of quality of life. And there was also a qualitative component too, where we actually interviewed parents to understand their views on SDF, because again, arrest rates are one thing, but parental acceptance is a totally different issue. So we might think it's a great product clinically to use, but you know, the qualitative research really complements everything by letting us know what parents truly believe of the product. So in that pilot study that was published in 2000, we found that after the first application of SDF, so the blue is 4 months after the first application of SDF to cavitated caries lesions, we saw anywhere from 74 to 76 to 71% of lesions arresting. So overall, about 74% of all lesions arrested. In the anterior, about 76% of lesions arrested after the first application, and 72% after in the posterior lesions, those arrested after one application. After this, 4 months after a second application of SDF to those same lesions, we saw quite considerably higher arrest rates. So this was in a young population and gave us the first sort of Canadian evidence of the effectiveness of this product. As well, by tooth type, again, I won't sort of focus too much on this apart from saying there's generally great success in the maxillary anterior area. With SDF, what we've seen, our posterior areas are often where we see the most number of challenges, often because of food impaction and difficulty cleaning. And with this, we had a few individuals where we didn't see great necessarily success on lower canines, but again, there were only 2 such teeth in the study at that time, so wouldn't focus too much on that. Overall, anterior interproximal arrested quite well, with 98% of the lesions in the anterior regions arresting interproximally. But the posterior interproximal is where I think most of you, if you've used product in clinical practice, that's probably where you're feeling that perhaps you're failing. And I don't want you to think that you're failing. I think we just need to be mindful that in the posterior areas, especially interproximally where it's cavitated, those are plaque traps. So that environment, that perfect breeding ground for caries is continually there. And so we need to make sure that hygiene, oral hygiene is also well maintained in these patients who are receiving SDF applications. So just one little quick slide on sort of what parents thought at that time with that pilot study. So I think the interesting thing is parents were willing to recommend SDF. Almost all parents in that study said they would recommend SDF to other parents as a way to non-restoratively manage SDF or manage ECC, so early childhood caries. And again, this was pre-COVID. So again, I think we definitely, I'll mention in a little bit, the uptake and the parental interest in SDF grew, I think, during COVID. Some had actually recommended to others, and some of their quotes are there. And even though parents sort of did express a little bit of concern over the aesthetics that SDF, impacts, many indicated that their preschoolers were really not too concerned with the black staining of the caries lesions, probably because they were too young and didn't really care. Some mentioned that it did improve and address sensitivity. I think the problem is we heard some parents say that their concern is, once they go to school, and they start becoming that nursery school age, the kindergarten age, that's when parents start realizing, my child has SDF treated teeth. They're going to kindergarten. What are the kids going to say? What are the teachers going to say? And that's when they started to think about it. So I'm now going to delve into our randomized clinical trial of different SDF application intervals to arrest dental caries. And so since its arrival on the marketplace in 2017, there's been, I think, great uptake of SDF. But at times I'm finding there's conflicting guidance and maybe lack of real consensus on what is the appropriate frequency between applications and how many applications do you need, and are each of the different sort of regimens that are being proposed all equivalent. And so this really came with, I sort of thought of this idea with others because one of our challenges is particularly in dental public health, we don't always have the luxury and time in our schedules to bring children back, within a matter of weeks for another follow-up application of SDF. So our thinking was, considering we knew 4 months in between applications worked well in the pilot study, others are suggesting, 1 month between applications. And I know, Advantage Arrest is advertising and promoting, a reapplication within 3 weeks of the first application. We wanted to look at that. And others were saying, well, no, every 6 months is quite sufficient. So that was the purpose of this study, to see is, will we get the same arrest rates with 3 different application regimens? So 2 applications, our hypothesis was at different frequencies will yield similar arrest rates. So we sort of thought, well, maybe they'll all perform similarly. And we also had the ability within a subset of this patient cohort to look at potential influence on the oral microbiome. So our main objective was to determine the effectiveness of the different application regimens to treat SDF, and subsequently other sort of secondary objectives were to look at potential shifts in the oral microbiome, and also look at what's the impact on the oral health quality of life in young kids. So we had a total of 84 participants that were recruited into this randomized clinical trial, and we recruited from some of our primary or public health clinics in Winnipeg, Access Downtown, Mount Carmel Clinic, and Smile Plus. And this was then a prospective study, so ongoing over time. We had approval from our U of M's Biomedical Research Ethics Board to ensure that we were following best research practice. Our inclusion criteria for this study is children needed to be less than 72 months of age, so aligning with the case definition for early childhood caries. And particularly, we were looking for cavitated lesions in the ICDAS 5 and 6 range, so that this way we would be able to probe the lesions. So in the earlier sort of ICDAS caries stages, you can't probe the lesions if it's within a fissure, right? So we actually needed to be able to probe the dentin. And we excluded kids if they reported a history of silver allergies, if they had a condition already that was affecting enamel, such as a developmental enamel defect, severe medical issues that would make participation in the trial difficult, and if they sort of had teeth that were beyond SDF treatment. Because of the young age, so I know I'll speak later about clinical guidelines and how to use and the importance of maybe following up teeth with radiographs. Because of the young nature of this population, and because we were using SDF because children had caries but difficult to manage restoratively, you can imagine the difficulty as well in trying to take radiographs. So radiographs were not part of our existing study protocol. If the children would have been older, that would have been definitely something we would have done. So we randomly assigned based on sort of random envelopes containing the regimen. Children were randomized into 1 month, 4 month, and 6 month groups. Parents or the caregiver completed questionnaires with our study team, looking at sociodemographic characteristics, oral health related quality of life, pain, oral hygiene practices, and appearance of teeth. And at each visit, dental examinations were performed. So at the first visit, which is baseline, we measured lesions, we looked at them and assessed them for hardness, very crudely, but this is often what is done in the research studies as with a ball-ended probe, soft, medium, or hard. And then we gauged the color of the lesion, yellow, brown, or black, and its activity. So no caries excavation was performed. I know there's often discussion out there, do I need to remove caries before I apply SDF or not? We did not in this study, and I'll just be, a piece of information, realizing the silver goes into the lesion. If you actually remove part of the caries lesion before treatment, you actually have less of a barrier, so potentially there could be irritation of pulpal tissues. So SDF was applied for up to 1 minute, but again, dependent on the child's cooperation. And then we followed the SDF application by applying 5% sodium fluoride varnish, and the product we used was Nupro. Caries lesions, we considered them in our analyses to be arrested if we saw that the dentin was hard on probing and the color was black, and that there were no signs of irreversible pulpitis or infection. So again, we use sort of a higher sort of standard. Others sort of may sort of say a brown lesion that's hard is the equivalent to a black lesion. That's hard. For our study, we said the lesions needed to be both black and hard on probing to be considered successfully arrested, and one examiner doing the assessments. So this is sort of our diagram sort of showing the period. So we started the study just prior to COVID happening, and then we were really concerned, COVID's gonna really kill this study. But surprisingly, we actually, because dental offices weren't performing aerosol procedures and many offices were closed, we actually saw more parents interested in this and willing to participate in the study, because really there was no alternative at the time for their child. And we also had to go to the university and lobby them, because at one point they were saying, oh, clinical research must stop. Only cancer trials should continue, or other medical clinical trials. So we actually had to nicely say, well, why is dentistry excluded from clinical trials? This is a clinical trial, just like other medical clinical trials out there with products. And if we're following proper protocols, there is no reason why we shouldn't. And so the university did permit us and gave us exemptions, and we're able to continue. So showing that at the first visit, the teeth were assessed, questionnaires were completed, and that's when the first application of SDF was applied. And then depending on the regimen, children were either brought back within a month or in 4 months or in 6 months. And that point was a second visit. Arrest rates were sort of checked at that time, a follow-up questionnaire again, and a second application applied. And so in the end, we're following 28 children in each group. We also undertook microbiome analysis. So if questions come up about the microbiome, I'm probably going to defer to our postdoc fellow, Dr. Cruz de Jesus. But the new sort of ways, the new methods to look at the microbiome really focus on this molecular aspect, looking at 16S rRNA gene amplicon sequencing. And so it's very expensive. And so we only looked at, I think, 12 or 15 children in each of the groups and took sampling at baseline, at the second visit, and at the final visit to look at potential changes in the microbiome, specifically bacteria and also fungi. And as well, because it's important when we're doing sort of alternatives to restorative treatment, it's, I think, important and ethical to look at, are there other metrics that we need to capture? And so we collected information on the child's early childhood oral health, their quality of life, using this ECOAS tool that includes different domains, including a child impact section with 9 questions about their symptoms, difficulty eating or drinking, missed school days, interrupted sleep, being irritable or frustrated. And there's also a family impact section that sort of talks about parental distress. Have parents felt guilty? Have they felt upset because of their child's problems or dental treatments? And then again, family function. So I won't share too much about that, but do have 1 or 2 slides just to sort of give you the highlights on the microbiome and quality of life. So data were entered then into a REDCap database. We did our statistical analyses. And then for those of you who are really, expert statisticians out there, because, there were 2 children lost to follow-up, we performed intention to treat analysis, which is usually done in these types of studies. And basically we considered those lost to follow-up as unarrested lesions. So that needed to get factored in. So overall, we look at the mean age of participants here. So that first row, all participants, they were about 44 months of age. We did not see a significant difference at all between the 3 different regimen groups. So they were quite well matched for age and quite well matched as well for sex background. So we had slightly more males than females participating in the study, but still, I think, overall pretty good representation from both groups. And then our mean DMFT, if I sort of share with you there, overall no difference there. On average, children had almost 7 teeth affected by decay that were being followed up as part of the study. And we see that overall well balanced between the 3 groupings. And that's thanks to randomization. So there were 2 participants lost to follow-up. So 1 child in that 4-month grouping did not attend the 3rd visit. And at the time of the 2nd visit, we found that 4 out of their 8 treated lesions were arrested. 2 were in the anterior, successfully arrested, but only a third of posterior lesions. So again, when that child their data were analyzed in the final analyses, we kept these same arrest rates from the 2nd visit when we were analyzing final visit results. And then 1 child in the 6-month interval group did not attend either follow-up visits, and they had a total of 18 different lesions. And so again, that sort of makes things complex, but despite that, and even when after controlling for that, our stats still hold up, which is great. So let's look overall now at our arrest rates for children participating in this randomized control trial or clinical trial. So our first, I'll show you sort of this light sort of green band. So this is at their second visit. So it's the first follow-up appointment. So for all children, all lesions, we found that almost 75% of lesions arrested using this protocol at that they were arrested at the second visit. If we see in the 1 month group, we had 78% of lesions arrested after one application. In the 4 month group, 81% were arrested after that first application, but in the 6 month group, only 61% arrested. Going to the final visit, so this is following 2 applications, almost 90% of all lesions were arrested at that time point. Pretty similar results, I would say, between the 1 month group and the 4 month group. So keep this in mind for public health practice when people are saying, you know, oh, it's got to be within 1 and 3 weeks. Well, this is maybe here to suggest that if done sort of, if you follow guidelines, try for 1 minute and bring them back within a 4 month period, you will likely get very similar arrest rates. But it's the 6 month group after 2 applications where we still see less than 3/4 of the lesions being arrested. So again, when some people are saying, you know, every 6 months is all you need, that maybe is not necessarily the best guidance. If we look at anterior teeth, overall, after 1 application, about 79% of the lesions being arrested. Equal performance in the 1 month and 4 month groups after 1 application of SDF, and only about 2/3 of the lesions in the anterior region arresting at that 6 month follow-up. So again, is that because there's been so much time that it was arrested, but by the time they come back for follow-up, there's reversal of the lesion? Difficult to say, but likely that's factoring in. At the final visit or the 3rd visit, 90% of lesions were arrested after 2 applications. Again, very similar results, almost 99% success arrest rates between the 1 month and the 4 months groups. But again, just failing to reach 7 out of 10 lesions in the 6 month group. So if there's something to take home, we'll talk about that in a minute with conclusions. But I think important things to, important information here on maybe what's an appropriate regimen for clinical practice. Posterior arrest rates. So these are the tricky ones that I mentioned. These are the ones where you're going to find lots of food impaction and poor hygiene contributing to poor sort of success. So after 1 application, only 65% of all lesions were arrested. 63% in the 1 month group. Interesting, I can't figure this out, but this is research. 76% after 1 application in the 4 month group were arrested. And then only just over half of the lesions in the 6 month group in the posterior were arrested after the first application. Looking at the final sort of results in the posterior arrest rates, about 90% of the lesions overall were arrested. Good success in the 1 month group, 90%, and I would say good success in the 4 month group. The 6 month group is improved, but still we're only looking at less than 8 out of 10 lesions. So again, if we are applying this in clinical practice and not part of a study, we just need to be mindful of, you know, the likelihood that some lesions will not arrest, and how will we manage them, or will we apply even a 3rd application to potentially those lesions that are not arrested. So we found sort of two applications of the SDF in the 1 month and 4 month interval groups were extremely effective in arresting dental caries, but less so in the 6 month interval group. So I'll just sort of speak now, and thankfully, and a big thanks to our postdoc fellow, Dr. Viviane Cruz de Jesus, and one of our past pediatric dentistry residents, Mayura Manakar, who worked on this aspect here. So the diversity is just looking at, how diverse is the bacteria in the plaque. So looking at different species, but not the amount of the specific species, but how many can you actually tag in an assessment. And we basically found that there was no significant difference observed in bacterial diversity between visits. So whether it was baseline before SDF was applied, at the second visit, after one application, and at the final visit. So diversity there, certain bacteria did not drop out completely off the map, and others didn't necessarily appear, surprisingly, after SDF treatment. However, there was some shift in the relative abundance of particular bacteria. And again, this is a small subset. I think we're one of the first labs in Canada to do this. But we did show significant change in bacterial species, specifically lactobacillus and bifidobacteria, how they potentially shifted during the application process. And so I'll just sort of speak to here, for instance, Streptococcus mutans, which are these orange bands. And apart from this 1 second visit where it seems to be higher, generally speaking, in the 1 month group, in the 4 month group, and in the 6 month group, you will see that the band of orange actually is smaller at the final V3 visit compared with the baseline visit. So it sort of may suggest that SDF may have an impact on reducing some specific bacteria, but it's quite complex. And then as well, looking at the different fungi. So we are now realizing fungi have a role to play as well in caries development. It's not just bacteria, so the fungi matter. The pink bands are Candida albicans. It's not necessarily one that our lab has always identified being, associated with caries, because some of the other research that our teams looked at has actually found a different strain of Candida. This orange, or this sort of mustardy Candida dublinensis, is often a unique one that's different in kids with caries compared to caries-free kids. But definitely Candida albicans was highly abundant in all groups, regardless of the number of visits or regimens. Quality of life, I'll just simply say here, we did see an improvement in the total scores using this Early Childhood Oral Health Impact score or scale. So we saw the score decrease, which is a good thing. The lower the score, the better. So all children all around found improvement. The biggest ones were within the parental distress and family function. So maybe parents were relieved that actually their child's caries was being managed. We did not see a significant change in the child score among all the children. So that stayed the same. And it could be a matter of our sample size. We estimated our sample size based on lesions, the number of lesions, but not necessarily factoring in this metric. But it does suggest, I think, our study that we found no difference between the 3 different regimens as well. So again, they all seem to yield improvement in oral health related quality of life. So I think this is a good thing. We as providers and users of SDF can sort of rest assured that this product can improve oral health related quality of life in young kids when we're using it. Take some of the symptoms away and some of the family stresses away. So in conclusions with the randomized clinical trial, before I get into some tips, is 2 applications of 38% SDF with fluoride varnish to follow in the 1 month and 4 month groups were really effective. And I think it gives us good guidance for dental public health settings. So sticking with a 4 month interval, if that's as soon as you can get children in for your follow-up visits, or hygienists working with cohi in rural remote communities, again, you've got some reassurance that it will probably perform well. We found that the diversity of the microbiome did not necessarily change with SDF, but there may be an impact on the proportion of specific species of bacteria and fungi. So again, more to do there. And then as well, oral health related quality of life appeared to improve after SDF treatment. And so no differences were seen by the groups overall. So I'm just going to shift now just to some of my take-home tips. I hope it doesn't sound too corny, but I think, you know, as someone who's used it, I'm not saying I'm an expert in this. I'm still learning, I think, but I'm you know, quirky and I like to learn and discover things. So I think one of the biggest things that we need to make sure as providers is we need to make sure that we've obtained informed consent, because parents need to be aware of sort of, you know, the risks and benefits, and even adult patients must be aware of the risks and benefits of SDF. It might not always work, and they need to be informed that there's a chance that SDF may not arrest their caries. The chance of staining and irritation are there. So my advice is use the consent form. I know it's so easy to say, but just don't get yourself in a situation where you're going to get a patient complaint later on. And I put this image here again to emphasize the importance of consent. So here is a before and after. So quite substantial cavitated lesions on this young child in the anterior. And here's the post-treatment application. So I've had parents say to me, I knew you told me it was going to be black, but I didn't think it would be that black. So that's with a consent form, that's with clinical photos as part of the consenting process. So I think, you know, do your due diligence, and it's important to get consent from patients or caregivers of children or other dependents. Number two, tip two, familiarize yourself with clinical guidelines. So there are different guidelines that exist. American Academy of Pediatric Dentistry has clinical guidelines and a chairside guide. You know, we've got clinical guidelines that we developed for our Winnipeg Regional Health Authority. I imagine that COHI has their clinical guidelines and others. So again, follow them. It really offers guidance on case selection, step-by-step instructions for use, and again, follow up. So the interesting thing, I see one on a website, I see, you know, one that's sort of attached to SDF, the product, and it sort of says, you know, or guidance sort of saying, you know, maybe there's no follow-up needed. But, you know, that's not necessarily the case. I think it's not a once and done procedure, maybe like fluoride varnish. You still need to follow up individuals to make sure lesions are arrested. So there, I'm going to take you to evidence out of the United States, and thank God for the American Dental Association and their team of experts that they pulled together on these topics. They've developed evidence-based clinical practice guidelines for non-restorative treatment for caries lesions. I believe this came out in about 2018 or 2019. And again, I've highlighted in yellow what I want you to remember. For primary teeth on the crown surface, if it's the occlusal, the interproximal, or the buccal or lingual surface, if the lesion is cavitated and you want to manage it non-restoratively without fillings, SDF is what's recommended, 38%. Fluoride varnish is not going to get you anywhere with cavitated lesions. This is also a good document for you to look at the non-cavitated lesions and what you do in clinical practice, but beyond the scope of the talk today. But here, the red arrow, I'm going to emphasize, lesions must be monitored. You need to be recording in your clinical notes the hardness or texture of the lesion, the color, and if you are using radiographs, you need to do your due diligence and you need to put this in the notes, or else how are you going to know that things are working? Same with permanent teeth. If you've got caries that's cavitated on the occlusal, the interproximal, or the buccal or lingual surfaces, again, If it's cavitated, that means the enamel's broken through. You have a cavitation in enamel or a cavitation into dentin. 38% SDF is what this ADA expert panel is recommending. And again, the monitoring of lesions. Surprisingly, for root surfaces, they are not prioritizing SDF. So again, this is something that will need sort of more discovery, and it might be because of the lack of evidence or because SDF stains the root surface so much. But for root caries, if you are doing a geriatric population, you might be implementing SDF, but you also may want to consider 5,000 parts per million fluoride toothpaste or gel as well. Tip 3, case selection matters. So if someone's coming in, a parent's telling you that certain teeth, the child or they themselves are having, unsolicited or spontaneous pain, or there's, signs of potential pulpal inflammation, those teeth are not ones that should be considered for SDF treatment. You're just going to irritate things potentially. And, especially we've had this discussion with some people working with priority populations. You apply it without proper consent on teeth that maybe shouldn't get it. All you need now is for a child to get an abscess on a teeth that was already deteriorating, but that parent will go on social media and say to everybody that SDF caused this to happen in my child. So again, be careful. Avoid SDF to deep cavitated caries lesions. So if it's close to the pulp, you can't take a radiograph, maybe best not to apply SDF, think of something else. If you can take radiographs, that can help you in your decision making. So where people will talk, and I think we've all seen these videos about the super floss, dipping it in, going in between. From the AAPD, they're saying, perhaps the best way to apply SDF to interproximal areas where there are contacts is to place orthodontic separators first. So then after a few days, you can gain access to those lesions. SDF, you can include SDF into your restorative procedures, but again, I don't think there's any need for it to be used as a liner or a sealer under your restorations unless there's need for it. And again, if you're placing a deep restoration, do not place SDF first because of the same reasons in bullet 1 and 2. You potentially will irritate, and we've seen this happen where providers have applied and then children will come back potentially with a toothache. Again, if you are doing clinical care, you're doing a nice preparation, an MOD preparation on one primary tooth or a permanent tooth, and you can actually now visibly see the next interproximal surface on the neighboring tooth, and you see a white spot lesion there. Why not consider SDF on that lesion to arrest it and nip it in the bud? So tip 4, I sort of mentioned this already, checking to see if a lesion is cavitated, looking at the color and assessing the hardness, I think are going to be really important to you. So if you don't already have, get yourself some ball-ended probes, and then you can sort of start feeling the sort of lesion softness or hardness. Tip 5, this is a real practical one because you may have a child like this that's presenting with both white spot lesions and cavitated lesions. You want to apply SDF, but you may be worried, will the SDF flow and is it going to now stain and get integrated in these white spot lesions? And once that happens, you can't reverse it. And especially in aesthetic areas, even with permanent teeth, consider first applying a barrier such as fluoride varnish over sort of the incipient white spot lesions before you apply the SDF to the cavitated lesions as a way to minimize the risk of staining of those non-cavitated caries lesions. Tip 6, again, you know this, you're using this for different populations, the fearful, the apprehensive patient, the child who maybe you're trying to avoid the need for GA or they're already on a wait list for GA. Why not consider SDF to arrest caries, to prevent caries from progressing? Residents of long-term care and palliative care facilities, there's a role there with comfort care, your patients with special health care needs, those who have behavior or medical management challenges, Those, again, who also present with a mouthful of lesions and you can't get them treated on all one visit, again, you can consider SDF. And then maybe individuals who have challenges accessing care as a way at least to make sure caries doesn't progress. So in Canada, lastly, sorry, I'm taking a little bit longer than I had hoped. In Canada, SDF news, the Children's Oral Health Initiative with the Department of Indigenous Services Canada is now using SDF in its list of services as a way to manage children in First Nations and Inuit communities. During COVID, I think as a response to COVID, I won't speak for Dr. Hayes, but I think this COVID precipitated this sort of decision to include the non-insured health benefits program from paying and reimbursing dental providers for the topical application to hard tissue lesions of an antimicrobial or remineralization agent. So that includes SDF. And if you didn't know about this, you now do. For your NIHB patients, if they're 16 years of age and younger, you can bill 3 such treatments in a calendar year or within a 12-month period. If they're over that age range, it's 1 treatment in a 12-month period. Again, I'm trying to making you think, don't apply it under the restoration you're placing, but some will do it. This is really meant, I think, for the non-restorative management of caries when you should be billing for this code. Not sure with the upcoming Canadian Dental Care Plan, but my sense would be that the team at Health Canada, oral health branch is pretty bright and they're consulting with experts. So potentially we may see, I'm not promising this because I don't know what's in that, what's going to get covered, but I would hope that they will try to consider something that has good effect. And then again, decisions, hopefully future funders in Canada and insurance companies will start to cover SDF, but hopefully in an evidence-based fashion. In the US, we've got a policy statement from the American Academy of Pediatric Dentistry that's actually encouraging third parties to reimburse for SDF. They support SDF as an ongoing caries management plan, but realizing that children still and patients need to come for regular dental visits. And without sort of saying too much, AAPD, Council on Clinical and Scientific Affairs, the chairside guide is up for another review this year, as was last year, and some improvements will hopefully be made to wording. I've made some suggested edits. So that will come. And again, these chairside guides can be very helpful. This is probably the most interesting piece that I have found now on the horizon. So I know Dr. Taylor is aware of this as our Chief Dental Officer. In the United States now, there is actually a code for pediatricians to apply SDF to pediatric patients within the context of the medical home. So that's the medical clinic environment. And so they are drafting guidance for providers on how to use this. This is because already all 50 states in the United States will reimburse physicians and nurses to apply fluoride varnish and do screenings for at-risk children covered by Medicaid. And so this is another way to potentially increase the safety net. So you might be on the different sides of this argument. The reality is 75% or more of pediatricians are doing visual exams and doing oral health risk assessments and referring children to actual dental homes. More than 30% are already applying fluoride varnish in their practices, but just under 5% are applying SDF. So in closing, to thank our funders, the Children's Hospital Foundation or Children's Hospital Research Institute of Manitoba. Today is Giving Tuesday. So again, if you enjoyed this free CE, Daniela can give you an idea of how to make a donation today to the Children's Hospital Foundation of Manitoba, which funds CRIM. And today, I think every donation, every dollar you match, you donate is matched up to 3-fold. Thank you to our parents, to the clinical staff at the 3 clinic sites, our coordinator, Betty Ann, our residents and postdoc fellows, our study staff and team, and other lab members. So with that, I will stop talking, and thanks for your attention.
Thanks, Bob. So there's some questions coming up right now, and if anybody wants to ask, I see
Danielle, I'm just
Frank.
having a challenge hearing you, so I'm going to increase my volume. Sorry, hopefully people could hear me on the talk. So.
Yeah, if anybody has a question they want to ask, otherwise put them in the chat. Bob, just there's some that were up a ways. Somebody had asked how far past expiry date SDF can be used.
Yeah, so that's a great question. So for the purpose of our study, we didn't use expired product just because we wanted to make sure. I think, best practice, we probably shouldn't be using expired materials. Again, though, your clinic, your use of SDF may not be that frequent. So to buy a bottle that you might only use, once a week or less, you will likely then be going through that further. So I'm not sort of going to advocate to use expired product, but I will say that I have encountered in some clinics that I do see it there. I think that maybe should be maybe another study in future is to sort of see, how like the effectiveness, how does it decrease over time? So maybe that's something that could be done, and maybe someone in the dental material space could do that. But I would just avoid, because again, if you want to make sure that you are doing as much as you can to try to successfully arrest lesions. So probably adhering to manufacturer's instructions, just like our reprocessing of instruments, we have to follow guidelines. Thanks.
Okay. Here's a question. If you were head of dental school program, would you implement SDF applications on permanent teeth?
Yeah, so I think, so again, denoting cavitated versus non-cavitated lesions. My advice would be for a school-based program, make sure that you're getting parental, consent. So if you are sending information home to the parents, make sure, again, we realize, because I've given fact sheets home working in public health clinics, knowing that the fact sheets don't always make it home to parents. So again, maybe if you're wanting to introduce SDF, maybe another layer of connecting with parents either by the phone or some sort of virtual consultation, so they can maybe see the photos of before and after, explain maybe where you're going to place it. Again, this could be useful potentially for really apprehensive children, maybe on a permanent first molar where there's occlusal caries that's cavitated, you want to nip it until maybe you can do more restorative technique. But again, getting that parental consent. I know some of the school programs will rely on a negative consent for screenings and maybe fluoride varnish, which I think is okay, but maybe something with SDF, I probably wouldn't feel as equally comfortable using a negative consent for SDF. But I think it has space, just like sealants can be done through school-based programs. I think with proper parental education consent, it could be included for sure.
Another one, from an application standpoint, do you know what the uptake of SDF is if you can't get the tooth totally isolated?
Yeah, so we factor that in a little bit into our study, so I don't present the data today on that, but we did measure behavior of the child, because there are some instances, again, you're using this on children who often wouldn't cooperate for traditional restorative, right? So be mindful that you're going to have probably arms moving around, crying, spitting. So do the best that you can. So we recorded that. So we will do further analysis to see. So again, patient behavior, I think at the time of application and as pristine conditions as you can get, I think heightens your success, as does sort of making sure that there's good oral hygiene and use of fluoridated toothpaste afterwards. So I guess if you're really unsure of, did I get that well? Patient was, gagging, whether it be an adult or a child, probably bring them in for a future follow-up. And maybe you might, instead of 2 applications for that type of patient, you may need a 3rd application potentially. And again, not saying 2 is all you need. Again, there are children that I brought back just because I've realized, okay, it's showing signs of moving towards arrest, but I really want confidence, so I will occasionally bring children back for a third. And some teeth, kids might have 80% of the lesions arrest with 2 applications. There might be the other 10 or 20% that need a third or more applications.
And then why is fluoride treatment done after SDF application?
Yeah, so the thought here was to put the fluoride varnish over top of the SDF as a way to sort of create a barrier to make sure then less chance of the SDF sort of leaching out of that sort of treated cavitated area. So by putting the SDF as a barrier on top, you're sort of keeping that contact time of the SDF product with the caries lesion longer and hoping for increased arrest. So that's sort of the thought there.
Don't know if I've missed any. If I have, I don't think I have. But
that same person just asked if there was any evidence of research of that efficacy in that protocol that you just mentioned.
So we use that, thanks for chiming in. So we also use that same protocol in our pilot study. So that has been published before. And I believe that there are a couple of labs or research teams in the US that have also sort of followed that sort of type of protocol as a way, just extra protection to make sure SDF, doesn't, perhaps if a child quickly drinks something afterwards, are you actually going to get the SDF washing away by putting the fluoride varnish, you've got that potential longer time of SDF interacting with the caries lesion.
I think Dr. Olatosi just made a comment in regards to the guidelines.
I've got so many that says 40. Oh, lots of messages. Okay, the entire dentition may be treated. Yes, yeah, with 5% floating sodium varnish. Yeah. So, yeah. Okay, thank you, Dr. Olatosi. So
there is a question: can SDF go beneath the sealant?
So that's maybe another topic for another day. So, SDF. Is really used for cavitated lesions, but just maybe another talk for another day is we can actually, again, based on evidence from the American Dental Association, if we see non-cavitated caries beginning in pits and fissures, and so long as we don't see extension sort of through the enamel of sort of discoloration in the dentin, if the incipient caries lesion is contained within the pit and fissure, we can actually place a sealant over top of that. That is actually appropriate treatment. So you could theoretically apply SDF on it and then the sealant, but I think the current guidance and evidence would suggest that even just simply putting the sealant on top of an incipient lesion that's not cavitated on a pit and fissure is sufficient.
So just one more question, because I see we're at time, but how do you manage to remove SDF stain after first application if parents change their mind, even with consent?
Yeah, so this is where this product, there is no sort of companion product. I know with the other one on the market, I believe Rivastar, they do have potassium iodide that can be applied to remove the staining. I think as part of the consent form, you talk about the black sort of being like the scar. It's that reminder that it's worked. My sort of concern is, if you apply sort of potassium iodide and the color disappears, how do you know then if it's successfully arrested? But I guess you'll just rely on hardness alone. You can occasionally, so some of our older preschool children, as they get ready for to start kindergarten or preschool, I will sometimes bring them in, especially if parents have huge concern, and place either glass ionomer or resin restorations over top, because we do know from the literature as well, SDF doesn't necessarily have a negative impact on bonding of resin restorations. I think you still just want to make sure you've got good cavity preparation, but SDF can be covered up with aesthetic restorations, although you might see the circumference, right, a little periphery of shadowing, or maybe a little bit of shine through of your SDF underneath the composite or GI.